Hello, and welcome to the Home Health Training Part 1. I'm Teresa Mata, and I will be presenting Social Determinants of Health and new revised items for Sections A and B. I've been a registered nurse for 30 years and have experience in direct patient care, education, nursing administration, quality improvement and measurement, as well as the development of post-acute care patient-resident assessment instruments. My experience includes inpatient care in long-term care facilities and assisted living, as well as a nurse consultant at the Centers for Medicare and Medicaid Services, assisting with the implementation of the IMPACT Act. Currently, I am a Health Research and Evaluation Associate at Apt Associates in Cambridge, Massachusetts. Now let's look at some objectives for today's training. At the conclusion of this training, you should be able to discuss the social determinants of health, or SDOH, data elements and their significance in the assessment process, define and discuss the new revised non-SDOH data elements in Section A, Administrative Identification Information, as well as in Section B, Hearing, Speech, and Vision. You also should be able to summarize the implications for these data elements in your agency. Let's take a look at the implications of these data elements in home health by reviewing the changes that have been made. The new SDOH data elements added for home health are listed here and include A1005 ethnicity and A1010 race, which replace item M0140, A1100 language, A1250 transportation, B1300 health literacy, and D0700 social isolation. There are also new non-SDOH data elements for home health. These include A2120 through A2124, transfer of health information, B0200 Hearing, and B1000 Vision, which replaces M1200. Before we get into the actual section-by-section review, there are new data elements that have been added under the umbrella of social determinants of health. And we want to take a moment here to discuss what social determinants of health are. SDOH are the conditions in which people live, work, learn, and play, and they affect a wide range of health risks and outcomes. Several SDOH data elements have been added to the Centers for Medicare and Medicaid Services, or CMS, post-acute care, or PAC, assessment instruments, and conform to the 2011 Health and Human Services data standards. Capturing standardized SDOH data helps to understand factors at an individual, community, and population level. It helps to improve quality of care and health outcomes, document and track health disparities, allows for the comparison of SDOH data within and across PAC settings, and supports the collection and sharing of data across certification, policy, and coordination agencies and stakeholders. So let's start now by reviewing the SDOH data elements in sections A, B, and D. I will be referencing the Outcome Assessment Information Set, or OASIS-E instruments page numbers throughout this presentation. So it may be helpful if you have the OASIS-E instruments available as you review this presentation. The OASIS-E instruments can be found on pages 302 through 371 of the OASIS-E manual, found on the CMS OASIS User Manuals webpage. Please note that this manual is in draft form, so these numbers may change. As reviewed previously, these are the 6 standardized SDOH patient assessment data elements in sections A, B, and D that we will be reviewing. The first SDOH data element that we will review is A1005 ethnicity, followed by A1010 race. This is a snapshot of the data element, as you will see on page 2 of the OASIS-E Start of Care, or SOC instrument. As you can see, A1005 ethnicity is a check all that apply data element that is conducted at SOC. We will discuss what this means when we review the coding instructions in a few moments. And here's the snapshot of the A1010 data element race, which is also collected at SOC. As you can see here, and on page 2 of the OASIS-E SOC instrument, there are 14 different race categories listed along with 3 other response choices. Like ethnicity, the race data element is a check all that apply data element. The rationale for collecting this new information on ethnicity and race is to improve understanding of and address ethnic disparities in healthcare outcomes. Both ethnicity and race data elements provide the data granularity that is important for documenting and tracking health disparities and conforms to the 2011 Health and Human Services data standards. Collection of ethnicity data and race data is an important step in improving quality of care and health outcomes. Standardizing the collection of self-reported data across multiple PAC settings allows for the comparison of that data within and across these settings. An important thing to remember is that when collecting this data, these ethnic and racial categories are not used to determine eligibility for participation in any federal program. Here are the response-specific instructions that an assessor would use to complete these data elements. The first thing an assessor should do is ask the patient to select that category or categories that most closely correspond to the patient's ethnicity and race from the lists in A1005 and A1010. Now, some people may be uncomfortable answering the ethnicity and race questions. So to allay any concerns, the assessor should introduce the ethnicity and/or race questions by saying, we want to make sure that all of our patients get the best care possible, regardless of their ethnic and/or racial background. The respondent should be offered the option of selecting one or more ethnic or racial designations, because remember, this is a check all that apply data element. These data elements should be completed as close to the start of care or SOC as possible. Of note, if the patient is able to provide a response, the assessor will check the box or boxes indicating the ethnic or racial category or categories that were identified by the patient. If the patient is unable to respond, a proxy may respond for the patient. If neither the patient nor a proxy is able to provide a response for these data elements, you may use medical record documentation. The only time you cannot use a proxy response or medical record documentation to respond to these data elements is if the patient declines to respond. These are the coding instructions for the response-specific information we just reviewed. You are to use code X if the patient is unable to respond. Again, if a response is made by proxy, but if a proxy is not available to provide a response, medical record documentation may be used. If a response to this data element is determined via proxy or medical record documentation, the assessor would code the appropriate category or categories, as well as checking code X. If the patient is unable to respond and there is no proxy or medical record documentation available to provide this information, the assessor is to check only code X, patient unable to respond, and no other response. Code Y, patient declines to respond, is to be used in cases where the patient declines to respond. Remember from the response-specific instructions that if the patient declines to respond, you cannot use a proxy or medical record documentation to answer the question, even if there is a proxy and medical documentation that could provide this information. In this instance, only code Y would be checked. For A1010 race, there is an additional response code, code Z, none of the above. This is checked if the patient reports or it is determined via proxy or medical record documentation that none of the listed races applies to the patient. The next SDOH data element is A1110, language. Like the prior two data elements, A1110, language, is collected at SOC as close to the time of start of care as possible. Here you see the snapshot of the data element as it appears in the OASIS-E on page 3 of the SOC instrument. The rationale for collecting this data element is that language barriers can lead to social isolation, depression, and patient safety issues, as well as potential interference with accurate assessment of the patient. To complete this data element, the assessor will ask the patient for their preferred language. This response will be entered into the text field provided in A2120. A, what is your preferred language? Next, the assessor will ask the patient if they need or want an interpreter to communicate with a doctor or healthcare staff. This response is a simple no, yes, or unable to determine. If the patient or an interpreter, if one is used, is unable to respond to either question in A2120A or B, a proxy response is permitted. If neither the patient nor a proxy is able to provide a response to either question in A2120A or B, medical record documentation may be used to answer these questions. And again, this data element is completed as close to the time of the SOC as possible. Let's look more specifically at A2120A. What is your preferred language? For A2120A, the assessor is to enter the preferred language that the patient primarily speaks or understands. If the patient or any available resource cannot or does not identify their preferred language, the assessor should enter a dash symbol in the first text box. A dash indicates no information, and although a dash is an acceptable response for this data element, CMS expects dash use to be a rare occurrence. For A2120B, do you need or want an interpreter to communicate with a doctor or healthcare staff? Code 0, no, if the patient indicates they do not need or want an interpreter to communicate with a doctor or healthcare staff. If the patient is unable to indicate the need or want of an interpreter, proxy input may be used to answer the question. If the patient is unable and a proxy response is not available, then medical record documentation may be used to answer this question. The assessor would choose code 1, yes, if the patient indicates the need or want of an interpreter to communicate with a doctor or healthcare staff. Similar to A2120A, if the patient is unable to indicate the need or want of an interpreter, a proxy may be used. And if the patient is unable and a proxy response is unavailable, medical record documentation may be used. There is an additional response available, code 9, unable to determine. If no source can identify whether the patient wants or needs an interpreter, the assessor would enter code 9 as the response to this data element. A dash is not a valid response for this item. Here's a coding tip for A2120. If a person reports that their preferred language is American Sign Language, this information can be entered into A2120A. What is your preferred language? This is the final SDOH data element in section A that we will be reviewing. A1250, transportation. Again, here's a snapshot of the data element as it appears in the OASIS-E. A1250, transportation, is completed at SOC in resumption of care, or ROC, and discharge from the agency, and is a check all that apply data element. In the OASIS-E, you can see this data element on page 4 of the SOC, page 2 of the ROC, and on page 2 of the discharge from agency. This copyrighted data element is from the National Association of Community Health Centers and was adapted by CMS. The rationale for collecting this information is that access to transportation for ongoing healthcare and medication access is essential to effective care management. Understanding patient transportation needs can help organizations assess barriers to care and facilitate connections with resources available in their community. In order to complete this data element, the assessor should ask the patient the following 2 questions. In the past 6 months to a year, has lack of transportation kept you from medical appointments or from getting your medications? And in the past 6 months to a year, has lack of transportation kept you from non-medical meetings, appointments, work, or from getting things that you need? The patient should be told that they can respond yes to one or both of these questions if applicable. If the patient is unable to respond, a proxy response may be used. If neither the patient nor a proxy response is able to provide the information to answer these questions, medical documentation may be used. And if the patient declines to respond, the assessor cannot code this data element based on proxy input or medical documentation. This data element is completed as close to the time of SOC or ROC as possible, and is also completed within 3 days of discharge. That is, the day of discharge and 2 days prior. This is also a check that apply data element. The assessor will check code A, yes, if the patient indicates that lack of transportation has kept them from medical appointments or getting medications, and or code B, yes, if the patient indicates that lack of transportation has kept them from non-medical meetings, appointments, work, or from getting things that they need. If the patient indicates that a lack of transportation has not kept them from medical appointments, getting medications, non-medical meetings, appointments, work, or getting things that they need, the assessor will check code C, no. If the patient is unable to respond, this data element also provides code X, patient unable to respond. Recall that this code allows for the use of a proxy or medical record documentation to complete the data element. If code X is chosen because a proxy or medical record documentation provides the necessary information to respond, the assessor would check all boxes that apply, including code X. If the patient was unable to respond and there were no other resources that provided the necessary information, only code X would be checked. Code Y, patient declines to respond, would be used in cases where the patient declines to respond. If the patient declines to respond, you cannot use a proxy or medical record documentation to answer the question, even if there is a proxy and medical record documentation that could provide the information. In this instance, only code Y would be checked. We're now leaving section A and moving into the SDOH data element found in section B, health literacy. This is a snapshot of the health literacy data element B1300. This data element is completed on SOC, ROC, and discharge from the agency. It appears on page 5 of the SOC and on page 3 of the ROC and discharge from agency OASIS-E assessment instruments. Looking at the rationale for the collection of this data, we see that similar to language barriers, low health literacy can interfere with communication between the patient and provider. It can also affect the ability of patients to understand and follow treatment plans, including medication management. All of this leads to lower levels of knowledge of health, worse outcomes, the receipt of fewer preventative services, and higher medical costs, as well as the rate of emergency department use. Assessing for health literacy will facilitate better care coordination and discharge planning and help providers understand how their patients best learn information and how to support them in managing their health conditions. Here we have a definition of health literacy. It is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Because this data element is intended to be answered solely by the patient, that is, via self-report, no other source may be used to identify the response to this data element. In order to complete this data element, the assessor will ask the patient, how often do you need to have someone help you when you read instructions, pamphlets, or other written material from your doctor or pharmacy? The coding instructions for health literacy inform the assessors and home health agencies that this data element is to be completed as close to the time of SOC, ROC as possible, and within 3 days of discharge. In response to the question, how often do you need to have someone help you when you read instructions, pamphlets, or other written material from your doctor or pharmacy, assessors will enter code 0, never. If the patient indicates never needing help reading instructions, pamphlets, or other written materials from doctors or pharmacies. Code 1, rarely, if the patient indicates rarely needing this help. They'll enter code 2, sometimes, if the patient indicates sometimes needing help, reading instructions, pamphlets, or other written materials from doctors or pharmacies. Or they'll enter code 3, often, if the patient indicates often needing this help. Or code 4, always, if the patient indicates always needing help reading instructions, pamphlets, or other written materials from doctors or pharmacies. The assessor would enter code 7, patient declines to respond, if the patient declines to respond, or could enter code 8, patient unable to respond, if the patient was unable to respond. And here's the final SDOH data element that we will review, D0700, social isolation. Here's a snapshot of the social isolation data element, which is also completed on as close to SOC, ROC, and discharge as possible. This data element appears in the OASIS on page 8 of the SOC, page 6 of the ROC, and page 7 of the discharge from agency OASIS-E instruments. Social isolation tends to increase with age, is a risk factor for physical and mental illness, and a predictor of mortality. Assessing social isolation can facilitate the identification of patients who may benefit from engagement efforts and improve quality of life. Interventions to increase social engagement of patients should be designed and implemented while also taking into account individual needs, such as disability and language, and preferences like cultural practices. Here's a definition of social isolation. Social isolation refers to an actual or perceived lack of contact with other people, such as living alone or residing in a remote area. Note that, like the health literacy data element, the social isolation data element is intended to be completed via patient self-report. Therefore, no other source may be used to identify the response. In order to conduct this assessment, the assessor will ask the patient the following question: how often do you feel lonely or isolated from those around you? The coding instructions for social isolation state that this data element is to be completed as close to the time of SOC, ROC, and discharge as possible. In response to the question, how often do you feel lonely or isolated from those around you? Assessors will enter code 0, never, if the patient indicates never feeling lonely or isolated from others. Code 1, rarely, if the patient indicates rarely feeling this way. Code 2, sometimes, if the patient indicates sometimes feeling lonely or isolated from others. The assessor would choose code 3, often, if the patient indicates often feeling this way. Code 4, always, if the patient indicates always feeling lonely or isolated from others. The assessor would enter code 7, patient declines to respond, if the patient declines to respond, or code 8, patient unable to respond, if the patient was unable to respond. Now let's move on to a few standardized patient assessment data elements that are not considered under social determinants of health. The non-SDOH data elements we will be reviewing first are actually a series of data elements called transfer of health information. These data elements encompass data elements A2120 through A2124. Let's review the terms that are important for the assessor to understand when completing these data elements. At the time of transfer or discharge means as close to the actual time of transfer or discharge as possible. This time may be based on facility, state, or federal guidelines for data collection at discharge. Current reconciled medication list refers to the current list of a patient's medications that were reconciled by the agency prior to the patient's discharge. Means of providing a current reconciled medication list refers to the ways a reconciled medication list can be provided at the time of discharge. This can include both active and passive means. Active means could be via mail, electronically, or verbally. Passive means could be via upload to a common electronic health record, or EHR, or provider portal. An EHR, or electronic medical record, is an electronic version of a patient's medical history maintained over time. A portal is a secure online website that gives providers, patients, and others authorized convenient 24-hour access to personal health information from anywhere that has an internet connection. You can find additional information related to EHRs, EMRs, and portals in the OASIS-E manual. Let's first review data elements A2120 and A2121, which relate to the provision of a current reconciled medication list to the subsequent provider at transfer and discharge. This is the snapshot of A2120 as seen on page 2 of the OASIS-E transfer instrument. A2120 is completed as close to the time of transfer as possible and asks at the time of transfer to another provider if the agency provided the patient's current reconciled medication list to that subsequent provider. And here's the snapshot of A2121 as seen on page 3 of the OASIS-E discharge from agency instrument. A2121 is completed as close to the actual time of discharge from the agency and asks at the time of discharge to another provider if the agency provided the patient's current medication list to that subsequent provider. The rationale for collecting this data is that the transfer of a current reconciled medication list at the time of discharge or transfer can improve care coordination and quality of care, and can help subsequent providers reconcile medications and may mitigate adverse outcomes related to medications. It is critical that communication of an accurate reconciled medication list from one healthcare setting or provider to another is accomplished, as it ensures safe and effective transitions of care. The guidance for data elements A2120 and A2121 are the same, except that one data element is used for transfers and the other for discharges. At transfer, assessors will complete A2120 only if the assessment is currently being completed for either of these two reasons listed in M0100. Number 6, transferred to an inpatient facility, patient not discharged from the agency. Or number 7, transferred to an inpatient facility, patient discharged from the agency. At discharge, assessors will complete A2121 only if the assessment is currently being completed for the following reason listed in M0100. Number 9, discharge from the agency. And if the discharge disposition in M2420 is either number 2, patient remained in the community with formal assistive services, or number 3, patient transferred to a non-institutional hospice. Based on the responses in M0100 for A2120 and in M0100 and M2420 for A2121, the assessor would code 0 no if at transfer or discharge to a subsequent provider, the agency did not provide the patient's current reconciled medication list to that subsequent provider. If the assessor chooses code 0 no, they would move ahead to the next active data element. Again, based on the responses in M0100 for A2120 and in M0100 and M2420 for A2121, if at transfer or discharge to a subsequent provider, the agency did provide that current reconciled medication list to the subsequent provider, the assessor would code 1 yes, and then move to complete the next data element, A2122, route of current reconciled medication list to subsequent provider. For A2120 only, the assessor would code 2 NA or not applicable if at transfer to a subsequent provider, the agency was not made aware of the transfer timely and was therefore unable to provide the patient's current reconciled medication list to the subsequent provider. Here are a couple of coding tips related to A2120 and A2121. Patients may receive care from other providers after discharge from the agency, such as primary care providers, other outpatient providers, and treatment centers. It's important to note that these locations are not considered to be subsequent providers for the purposes of coding this item. The facility should be guided by current standards of care and any applicable regulations and guidelines, such as conditions of participation, in determining what information should be included in a current reconciled medication list. There is additional guidance that can be found in the OASIS-E manual, so please take some time to review this information. But here's a short summary of some of the key elements that may exist on a reconciled medication list. These include, but are not limited to, demographic information, allergies, adverse reactions, special instructions, the purpose or indication for use of the medication, and current prescribed and over-the-counter medications. While this information serves as guidance, the completeness of the medication list is left to the discretion of the provider and patient. So where can you find information related to medication lists? Documentation sources for reconciled medication list information can include electronic and/or paper medical records. Some examples of such records are discharge summary records, medication and intravenous medication administration records, home medication lists, and physician orders. Here's the next data element in the series of transfer of health information, A2123. Provision of current reconciled medication list to patient at discharge. Here's a snapshot of A2123 as it appears in the OASIS-E discharge from agency instrument on page 3. Note that this data element is completed on discharge from the agency, which, if you remember from our review of important terms, means that it is to be completed as close to the actual time of discharge as possible. The rationale for collecting this data is that communication of medication information to the patient at the time of discharge is critical to ensuring safe and effective discharges. It also improves care coordination, quality of care, aids in medication reconciliation, and may mitigate adverse outcomes related to medications. It is recommended that a reconciled medication list, if provided to the patient, family, and/or caregiver, be provided in consumer-friendly, plain language so that it is clear and understandable. At discharge, the assessor will complete A2123 only if the reason for assessment completion is because the patient was discharged from the agency, or number 9 in M0100, and if the patient's discharge disposition, as documented in M2420, is listed as 1, patient remained in the community without formal assistive services, or 4, unknown, because the patient moved to a geographic location not served by your agency, or UK, other unknown. The assessor would code 0, no, if at discharge to a home setting, the agency did not provide the patient's current reconciled medication list to the patient, family, and/or caregiver. If, when the patient was discharged to a home setting and the agency did provide a current reconciled medication list to the patient, family, and/or caregiver, the assessor would code 1, yes, and then move to complete the next data element, A2124, route of current reconciled medication list transmission to patient. For A2123, the recipient of the current reconciled medication list can be the patient, family member, and/or caregiver. It is not necessary to provide the current reconciled medication list to all of these recipients in order to code 1, yes. Now let's review A2122 and A2124, which are the last 2 data elements in this series, which speak to the route of the current reconciled medication list transmission to the subsequent provider or patient. Here's the snapshot of A2122 route of current reconciled medication list transmission to subsequent provider as it appears in the OASIS-E on page 2 of the transfer instrument and on page 3 of the discharge from agency instrument. Remember that when you are going to complete this data element is if the response to A2120 or A2121 is coded 1 yes. That is, a current reconciled medication list was provided to a subsequent provider at transfer or at discharge. Note that for this data element, you're going to check all that apply, and it is completed on transfer and or discharge only, as close to the actual time of transfer and or discharge as possible. And here's a snapshot of A2124, route of current reconciled medication list transmission to patient, as seen on page 3 of the discharge from agency instrument. This data element is only completed if A2123 is coded as 1 yes, and is completed only on discharge from the agency as close to the time of discharge as possible. The guidance we will review in a moment addresses the coding of the route of transmission to the subsequent provider at transfer, at discharge, and to the patient. The guidance is being combined here with specific instructions for either transfer or discharge as needed. The guidance for data elements A2122 and A2124 are the same, except that one item is used for the subsequent provider at transfer discharge, and the other one at discharge for the patient, family, and or caregiver. There is additional guidance for these data elements that can be found in the OASIS-E manual, so please take some time to review this information closely. The rationale for collecting the route of transmission of data elements is to monitor how medication lists are transmitted at transfer and discharge to the subsequent provider, and at discharge to the patient, family, and or caregiver. At transfer, the assessor will complete A2122 only if in M0100, the reason for assessment being completed is either 6, transferred to an inpatient facility, patient not discharged from the agency, or number 7, transferred to an inpatient facility, patient discharged from agency. At discharge, the assessor will complete A2122 only if in M0100, the reason for assessment being completed is number 9, discharge from agency, and the M2420 discharge disposition is either 2, patient remained in the community with formal assistive services, or number 3, patient transferred to a non-institutional hospice. Discharge, the assessor will complete A2124 only if in M0100, the reason for the assessment being completed as 9, discharge from agency, and the M2420 discharge disposition is either 1, patient remained in the community with formal assistive services, or 4, unknown because the patient moved to a geographic location not served by the agency, or UK, other unknown. In order to select the appropriate codes that correspond to the routes of transmission used, we need to understand what each of these response codes mean. It's also important to remember that this data element is a check all that apply data element, so multiple responses can be chosen. The assessor will check A2122A, A2124A, electronic health record or EHR, if the agency has an EHR and used it to transmit or provide access to the reconciled medication list to a subsequent provider, patient, family, and or caregiver. This can happen when both the discharging and receiving provider have direct access to a common EHR, or by providing the patient with direct access to their EHR medication information through a patient portal. It's important to note that checking this route doesn't mean that there has to be any kind of confirmation that the subsequent provider has accessed the EHR to obtain the medication list. We're just documenting here that the reconciled medication list was sent to the subsequent provider via this route, and or patient, family, and or caregiver. If the reconciled medication list was transmitted via a health information exchange or HIE, the assessor would check A2122, A2124B. An HIE is an organization to which a facility may participate, which allows for an electronic exchange of data with other authorized entities. In this case, our subsequent provider, patient, family, and/or caregiver. If the reconciled medication list was communicated verbally, either in person, by telephone, or video conference, to the subsequent provider, patient, family, and/or caregiver, the assessor would check A2122, A2124C, verbal. Finally, if the reconciled medication list was transmitted to the subsequent provider, patient, family, and/or caregiver using a paper-based method like a printout, fax, or electronic fax, the assessor would check A2122, A2124D, paper-based. And if this information was transmitted via other methods not listed here, the assessor would check A2122, A2124E, other methods. Examples of other methods would be via text, email, or a CD. The next data element we will review is B0200 Hearing. Here's the snapshot of B0200 Hearing as seen on page 5 of the OASIS-E SOC instrument. Please note that this data element is completed at SOC only. The rationale for collecting this data is that problems with hearing can contribute to sensory deprivation, social isolation, and mood and behavior disorders. Unaddressed communication problems related to hearing impairment can be mistaken for confusion or cognitive impairment. In order to complete this assessment, the assessor needs to ensure that the patient has their normal hearing appliance available if they use one. A person could be using a hearing amplifier or microphone in headphones or a hearing aid. So be sure that you know what appliance is used, if any, and ensure that it is operational and available. The assessor would then interview the patient and ask about hearing function in different situations, like when talking to visitors, staff, or family members, using the telephone, watching TV, or participating in a group discussion. The assessor should also observe the patient during regular verbal interactions that occur throughout the day. When thinking about assessing a patient's hearing ability, consider how you best communicate with the patient. You may need to speak more clearly or raise your volume, speak more slowly, or use gestures. The patient may also need to see your face, especially if they read lips, to understand what you're saying. Or you may need to move to a quieter area. Be sure to review the medical record for any documentation of a hearing issue and consult the patient's family, caregivers, direct care staff, and other staff or specialists as needed. Again, this data element is completed only at SOC as close to the time of SOC as possible. If the assessor determines that the patient hears and has no difficulty in hearing normal conversation and social interactions, listening to the TV, radio, using the telephone, etc., they should choose code 0, adequate. If the patient has minimal difficulty, meaning that they have difficulty in some environments, that is, if the setting is noisy, or if the person speaking to them speaks softly, but the patient's hearing is adequate after environmental adjustments are made, like reducing background noise or moving to a quieter area, the assessor should code 1, minimal difficulty. The assessor would use code 2, moderate difficulty, if in order for the patient to hear, people have to adjust their own volume, speak distinctly in order to be heard, or perhaps face the resident when speaking. Use code 3, highly impaired, if there is an absence of useful hearing. What this means is that the patient would only hear some sounds and frequently fails to respond or comprehend the speaker, even when maximum accommodations, such as increasing volume, speaking distinctly, or positioning face-to-face with the patient are used. A dash, meaning no information, is a valid response for this data element, although CMS expects dash use to be a rare occurrence. Here's a coding tip related to hearing. If a patient is unable to respond to a standard hearing assessment due to cognitive impairment, they will require an alternate assessment method, such as observing them in their normal environment. Pay attention to cues, such as whether the resident turns their head when a noise is made at a normal level, or if the patient seems to respond only to specific noises in a quiet environment, or responds only to loud noises, or doesn't respond at all. And this is the last data element we will be reviewing today, B1000 Vision. And here's the snapshot of this data element as seen on page 5 of the OASIS-E SOC instrument. This data element too is only completed at SOC. The rationale for collecting this information is that a person's reading vision often diminishes over time. If left uncorrected, vision impairment can limit everyday activities that the patient normally would like reading newspapers, books, correspondence, or even participation in activities. It can also limit the ability to manage personal business and sign forms. Moderate, high, or severe vision impairment can contribute to sensory deprivation, social isolation, and depressed moods. In terms of assessing vision, it's important to have adequate lighting. And adequate lighting means that it's lighting sufficient enough that a person with normal vision is comfortable to see fine detail. In order to assess vision, the assessor should ask family, caregivers, and/or direct care staff over all shifts, if possible, about the patient's usual vision patterns. Consider questions such as whether the patient is able to see newsprint, menus, or greeting cards that they may receive. Then ask the patient about their visual ability. Test the accuracy of these findings by ensuring that the patient's customary visual appliance for close vision is available and used, like eyeglasses or a magnifying glass, and ensure adequate lighting. Ask the patient to look at and read regular-sized print in a book or newspaper, starting with the headlines and ending with the smallest print. If the patient is unable to read a newspaper, provide material with larger print, like a flyer or a large print book. If a patient is unable to read aloud due to aphasia or perhaps illiteracy, the patient should be tested using other means, such as, but not limited to, substituting numbers or pictures for words that are displayed in the appropriate print size, like a regular print in a book or newspaper. For this data element, the same coding instructions apply as they did for hearing. As stated, this data element is completed only at SOC, as close to the time of SOC as possible. Once the assessor has completed the visual test, they should choose one of the following response codes that corresponds to the results of their findings. The assessor would code 0 adequate if the patient sees final detail, including regular print in newspaper and books. Code 1 impaired if the patient sees large print, but not regular print in newspapers and books. Code 2 moderately impaired if the patient has limited vision and is not able to see newspaper headlines, but can identify objects nearby in their environment. The assessor should code Code 3 highly impaired if the patient's ability to identify objects nearby in their environment is in question, but the patient's eye movements appear to be following objects, especially people walking by. Or Code 4 severely impaired if the patient has no vision, sees only light colors or shapes, or does not appear to follow objects with their eyes. Again, a dash is a valid response, but should be used rarely. And finally, here are some coding tips for B1000 Vision. Be aware that some patients have never learned to read or may be unable to read English. In such cases, ask the patient to read numbers such as dates or page numbers, or to name items in small pictures. Be sure to display this information in 2 sizes equivalent to regular and large print. If the patient is unable to communicate or follow your directions for testing vision, observe the patient's eye movements to see if their eyes seem to follow movement and objects. Though these are gross measurements of visual acuity, they may assist you in assessing whether or not the patient has any visual ability. For patients who appear to follow movements and objects, choose Code 3, highly impaired. So to summarize, we've reviewed the new SDOH data elements in sections A, B, and D, which were added to the OASIS-E to conform to the 2011 HHS data standards. We also reviewed some non-SDOH data elements that were added to the OASIS-E to achieve standardization across PAC settings. In closing, if you would like to submit a question regarding this presentation, please send it to pactraining@econometrica-inc.com by August 31st. As a reminder, a practice coding workshop will be held in September of this year, and we do encourage you to attend. Select questions will be answered in a Q&A session during this virtual live event. Thank you for reviewing this presentation, and we look forward to your attendance at the coding workshop.